I would now like to introduce Tricia McGinnis, who will lead our panel discussion this morning. Tricia is the Director of Delivery System Reform for the Center for Healthcare Strategies. And in that capacity, she leads initiatives to reform the delivery of care and financing of healthcare systems to both improve the quality of care and reduce costs of care received by Medicaid members. She has written numerous articles and practical guides and toolkits for states on Medicaid, accountable care organizations, and leveraging the primary care rate increases made available under the ACA. She's leading the center's Learning Collaborative on Medicaid ACOs and has become one of the nation's leading experts on the topic. We are very fortunate to have her with us here today. Please join me in welcoming Tricia to the panel.
Welcome, everybody. I'm very excited to be here with you as Massachusetts moves forward with its primary care payment reform initiatives. As Kate mentioned, we're seeing across the country other state Medicaid programs similarly at the forefront alongside Massachusetts. So what we wanted to do this morning was bring together a few of them to talk about the different approaches that they're using to apply payment reform and delivery system reform together to help really move forward in how care is delivered so that both quality is improved and costs are reduced. So I want to welcome all my panelists here. Just to give it some brief context, Kate mentioned that probably not surprising to you, each state looks alike. They say once you've seen one Medicaid program, you've seen one Medicaid program, and that's it. All of these models here in our panelists today have taken their state, unique aspects of their state model and really leveraged the foundation and strengths that they have underlying those models to develop new accountable care models and delivery system reforms. There are a few key components, though, I think, to any form of increased accountability. One, as Kate mentioned, is payment reform, and really changing the way providers are paid so that they can reap the rewards of innovation, of working directly with their patients, and changing the way that care is delivered. The second component really looks at collaboration and trying to shape a system where providers are working in a truly collaborative way, not only among one another, but with social service agencies, with community organizations, with other folks involved in the social safety net that can really help to improve the care delivery. The third component is really looking at a system that supports providers and building new capacities. This type of delivery system reform is not easy. We're really fundamentally trying to change the way care is delivered. So supporting the providers through that process, again in a collaborative way, is another key component of these models. Fourth is measuring quality. There's a lot of concern that as we change the way care is paid for, that there will be incentives to skimp on care. So first and foremost, we want to make sure that that's not the case. But secondly, we're looking at new aspects of care that haven't necessarily been measured before. So figuring out the right quality metrics that can help capture and truly help us understand whether quality is being improved for these patients. And then finally, the fifth element really is data. When managed care swept through the country in the 80s, we didn't have the degree of data that we have today. And we still don't necessarily have it at the point of care. It's definitely something that we're marching along. But that's really the fifth component that really is key to making these models work in a sustainable way. So I'm going to turn it over to my panelists here. Just wanted to give a brief overview because really the states have taken very, very different approaches. But I think there are elements of each that will be important as Massachusetts moves forward with its primary care payment reform efforts. In Colorado Medicaid, they have an accountable care collaborative, which creates regional care collaboratives that work directly with primary care practices to support community-based care and coordination efforts. Within New York, Medicaid is building upon their PCMH program to implement health home models that really look to see how physical health and behavioral health can be integrated across the primary care setting. Within Maine, Medicaid is looking to build what they call accountable communities, which builds upon Maine's existing patient-centered medical home model, incorporates health homes infrastructure, and provides shared savings to providers that come together to improve patient care and lower costs. And in Oregon, Medicaid is building upon their strong managed care infrastructure and environment to create coordinated care organizations, which accept global payments and work closely with providers and community organizations to develop coordinated care on the ground. So I look forward to hearing from our panelists and hope that after those discussions, we'll open that up for audience Q&A so that you can ask your questions as well. But first, I'd like to hand the mic over to Dr. Harris, who's going to give an overview of the Primary Care Payment Reform Initiative for Mass Health and set the stage for today's panel discussion.
Thank you, Tricia. I want to start by, first of all, also welcoming everyone to this event and to thank the Mass Medicaid Policy Institute for serving as our host and our colleagues at the Center for Healthcare Strategies for helping to convene this fantastic panel, as well as my colleagues from other states who we've had a lot of great conversations with over the past several months and have had an opportunity to incorporate some lessons learned from the work that they have done thus far. And our approach to thinking about how we should develop a model of accountable care within the context of the Medicaid program, we were very mindful of a vision and a commitment to primary care in the context of the patient-centered medical home, and the opportunity to think about how to actually achieve in practice what has been a long-standing goal here in the Commonwealth and many parts of the country. How do we actually bring together primary care and behavioral health care in ways that are much more integrated and coordinated for our members who experience their care in both of those systems? How do we actually shift away from the fragmentation that has characterized a number of components of our healthcare system to a model that is much more coordinated? I think that as payers, we often like to think that we're in a position to do a lot of the innovative work, but we recognize that our toolkit really is composed primarily of our approaches to paying providers. And providers have an enormous amount of work to do to think about how they actually, in practice, innovate in the way that they deliver care to patients. And so we've spent a lot of time thinking about how do we best support them, provide incentives, and give them the resources that are necessary to truly transform the delivery of care. Our payment mechanism has three components, and I'll go into these in more detail. But at a high level, there is what we call a comprehensive primary care payment, which is a capitated payment for primary care services and a subset of behavioral health services. There's a shared savings and shared risk option. And then there are quality incentive payments that are focused on rewarding providers for improvements in quality that are not necessarily tied to savings at the time that the measurements are taken. In our Medicaid program, we actually have a combination of what's called a primary care clinician plan, or a managed care plan that we, the state, run ourselves. And then we subcontract with 5 Medicaid managed care organizations. This program is actually designed to span both of those programs, and we've actually worked very closely with our MCOs in the design of our model and have benefited not only from their participation, but also the participation of one of our partners on the primary care clinician plan side, who plays an important role in managing our behavioral health network, as well as providing some care coordination support from the plan-based perspective to our members in the PCC plan. But the program is structured to span both programs. You all heard that we have a very aggressive time frame, and that time frame was put into statute as a part of Chapter 224, our healthcare cost containment law. So we are directed by statute by the beginning of next fiscal year to have 25% of our members across those two programs enrolled in our new model, in our primary care payment reform model, and by July of 2015 to have 80% of our members enrolled. So focusing now on our payment methodology, we began with the hypothesis that we needed to give primary care providers not only the resources, but the incentives to shift much more dramatically away from a fee-for-service mindset than some of the other approaches that we contemplated. And so we actually started with the foundation of our payment methodology, an approach that we call our comprehensive primary care payment. And this is a capitated payment for services that primary care providers would deliver themselves in practice, as well as a payment to reflect a subset of behavioral health services. And I'll talk in more detail about the options along the behavioral health spectrum. But at the end of the day, the goal of this payment is to try and change the behavioral economics of a practice so that they have the resources and tools that they need to deliver the right care at the right time, to be innovative around things like using email or phone calls to deliver care as an alternative to visits when that's an appropriate use of their time and their patient's time. But at the same time, to be flexible enough to be able to do an hour-long visit if you have a patient who has a problem list that is 10 problems long. And for those folks who are also clinicians in the room, you know that how challenging that can be to feel the pressure of a 15-minute visit when you have a patient who has that much complexity to navigate. The second component of the payment methodology is a quality incentive payment. When we looked at our work in the Patients in a Medical Home Initiative here in Massachusetts, we looked at a number of the medical home models that are in development or far along in other parts of the country. And we also looked at some of the early lessons learned from some of the Medicare models. What we saw is that providers are often able to demonstrate improvements in quality before demonstrate improvements in cost. And we wanted to recognize that and to have a component of the payment methodology that reflected that. And then the third component of the payment model is a path that includes options for shared savings and shared risk arrangements that I'll talk about in more detail. So we recognize that in our market, practices are in different places in terms of their level of sophistication and readiness for alternative payment methodologies. One of the things that's unique about Massachusetts for folks who are new to our state is that we already have, for our largest private plan, our Blue Cross plan, a model called the Alternative Quality Contract that is giving providers experience with these kinds of risk-based contracts. We have 5 Medicare Pioneer ACOs in the state, and we have 4 Medicare Shared Savings Program ACOs. So compared to a number of states in the country, we already have a substantial share of our provider landscape beginning to move in, if not already participating in risk-based contract arrangements. But we wanted to make sure that our model provided a path for most, if not all, providers to begin to participate and to move along this spectrum. So starting with track 3, we have an upside-only track that gives providers accountability for the total cost of care, but focusing on the providers in particular who do not have experience with risk-based contracts in the past. In track 2, providers are able to start with upside only and then transition over time to taking on some downside risk. And in track 1, the providers are starting with symmetric upside and downside risk. And we think track 1 will likely be most appealing to providers who are already in risk-based contracts with one of the private players in the state or in a Medicare risk-based contract, or a provider who has participated in a model like track 2 and is now prepared to transition to track 1. In all 3 of the tracks, the providers have to pass a quality threshold in order to receive shared savings. And the quality performance measures act as a multiplier, both on the upside and the downside. So if a practice is able to generate savings, but also has significant performance from a quality perspective, they actually get to participate in a greater share of those savings. And on the downside, if there's a practice that actually has not achieved savings or has actually seen less than ideal cost performance, but they've improved quality, their exposure to downside risk will be mitigated by a multiplier based on their quality performance. So we have a deep commitment to the notion that a medical home has the potential to truly be the locus for delivery system transformation. And when that medical home is working in partnership with or actually includes the delivery of behavioral health services, that we have opportunities to affect not only the delivery of outpatient primary care services and behavioral health services, but to impact the broader delivery system, to affect the use of acute care services on the behavioral health side and on the medical side. We also, because we are Medicaid, and Medicaid is in every state the major payer for long-term services and supports, we wanted to include an option for the organizations to also take accountability for the long-term services and supports costs as a part of their global budget, but not a requirement at the outset, because we recognize that providers are only beginning to think of their role from a care coordination perspective as including playing an important role on the long-term services and support side. But we felt it was important to at least begin to give providers an option to move down this path, because it is such an important part of what we do. It's a third of our budget. And for people who, as Phil Johnston described, who really care about the Medicaid program, you have to care about long-term care and to support our efforts to think about ways to facilitate greater coordination of long-term services and supports. And so in our notion of what a medical home would do, in addition to coordinating primary care and behavioral health services, we're hoping that we're going to have practices that are also taking on accountability for the long-term services and supports as well. In terms of the streams for providers to partner around the delivery of behavioral health services, in our sort of first lane from a behavioral health perspective, the providers are held accountable for doing better care coordination for behavioral health services, but not for delivering behavioral health services on site themselves. And the second model, they would deliver a limited set of behavioral health services on site. And in the third model, they would actually deliver a full range of both primary care and outpatient behavioral health services. So for example, we have some community mental health centers in the state that also serve as the site of delivery for primary care. And so in this model, those providers would actually deliver that full range of services and actually have all of those services reflected in their capitated payment. Because we're so committed to thinking about how we actually try to operationalize primary care and behavioral health integration, we're hoping to see providers move along the spectrum over time, but recognize that they're starting in different places. We've done a lot of work to try and understand how to support practice transformation, and that's included having conversations with folks at CMS who are working on the Pioneer and the Medicare Shared Savings programs. We've talked with our health plans who have had some experiences with supporting practices in some of their alternative payment work, as well as with some of our colleagues on the private payer side, but we recognize that learning collaboratives will need to play an important role. We also are working through how to support practices as they stand up their electronic health records. Massachusetts, for folks who don't know, became the first state in the country to launch a health information exchange that's built on top of our Medicaid IT infrastructure. And we're working to think about how to leverage that as a tool, not only for the efforts that we have in Mass Health, but across payers and providers in the Commonwealth. We know that the Medicaid incentive payment program that was made possible by the Recovery Act is providing important support to primary care practices. And we're working to think about how to support providers who are not receiving funding or support through that mechanism to be able to get some additional resources as well. And finally, we share with our private payer colleagues who are undertaking this work and with the federal government a commitment to ensuring that practices have timely and accurate data. And I think over time, as our all-payer claims database evolves, and particularly as our health information exchange evolves, there will be new and interesting ways to think about both receiving data from and sharing data with practices. So I'll stop there to make sure that my colleagues have enough time.
Thanks, Julian.